I'll blast through diabetes so you can get out on that slopes today. Looks like it's a nice day out there. Diabetic Emergencies, page 83. We're going to kind of do a meandering through a various smattering of diabetic emergencies because diabetes is a huge topic. And one of the things I'm not going to talk about is, because we'll talk about that the last day, is this new sort of swirling controversy about sugar control in diabetes, type 1 and type 2, and whether it's even a worthwhile endeavor, which is a fascinating topic because we all think it is and it may not be. We'll talk about that the last day. Today we're going to talk about some of the various and sundry little smattering of potpourri things that do with diabetic emergencies. And the whole first section in here, when Peter Vecellio, who wrote this chapter, kicked it off, he talks about some of the problems with our current medications, particularly insulin, in dealing with diabetes. Insulin is, most of us use human insulin, although there are now analogs of human insulin that are probably better. And the problem with human insulin is that its onset is pretty slow, its absorption is relatively unpredictable, and it's somewhat problematic to use as an agent, but it's the only one that we can give IV. Okay, so that's one of the issues so far with insulin, is that human insulin is the only one we can give IV. And in emergencies, that's something that's important, perhaps, in treating things like DKA. We'll come back to that in a sec. The other thing to know about insulin is you need to know a little bit about its metabolism. It's metabolized about 50% in the liver and about 30% in the kidney, which is important. It makes a big difference if somebody has liver failure or if somebody has renal failure, what their insulin dosing requirements may be and what their complications may be from getting insulin itself as well. Those of you that are primary care docs and write these prescriptions in your offices, you're pretty comfortable with knowing how important you have, how careful you have to be in writing these prescriptions. Writing out specifically which agent, because a lot of these agents sound a lot like each other. Humalog and Humulin. If you don't write that out clearly, they're different agents. They can be given differently by the pharmacist. Lenti versus Lantus. Write it carefully so that it's clear. When you write, I don't write these prescriptions in the emergency department, so I will beg, relatively, usually don't, I will beg sort of somewhat ignorance in the chronic management on insulin regimen therapies, but those of you that do write them know you've got to be very, very careful in how you write these particular prescriptions. For those of us that deal with hospitalized patients, and most of us in this room do, we basically use regular human insulin, and we use insulin, not orals. Orals are not good agents in the hospital. If somebody comes in with a diabetic complication, a problem from their diabetes, DKA is the biggest one we're going to talk about, you really need to use insulin. And insulin dosing is a three-part deal. You have basal needs, which is what all of us need all day long just to live. You need prandial needs. You just had your carb load. You need to cover that as well. And then if somebody has a stressor, you need sort of an extra on-the-top corrective need. So they have pneumonia. They actually need to have their diabetes sort of adjusted as well. You need to actually have all three of those as part of your insulin dosing in-house. That works out to about 0.7 per kilo in most adults. Half of that is a basal therapy. But you're putting three things in the hospital dosing, where in the outpatient dosing, it's basically just basal and prandial. So you're adding one little level to your dosing when you deal with it in the hospital. So it's just general sort of approach to the insulin concept itself. Let's talk about measuring serum blood sugars. Abstract number 1 is an interesting paper that tells me that I'm not sure what to do with this paper actually. I think you can't take home the message that is implied. What this paper did is they measured blood glucoses, and they measured them in the finger, the palm, and the forearm. Okay, so they wanted to see, because we do our finger sticks all the time. You do the little zappy thing. Those things hurt, by the way. Man, those buggers hurt. It's better to hit them on the side of the finger than the tip, because those things really hurt. They have to use their finger later. Anyway, if you poke somebody in the finger, that's where we do it mostly. And what this study wanted to see is there a difference here versus here in measuring particularly low blood sugars? So that's what they wanted to do here. They took healthy volunteers, 10 of them. This is clearly not a study done in the US. It's a Japanese study. Said, here, we're going to give you some insulin. You're a healthy person. I'm going to give you 0.1 per kilo of insulin. I'm going to let you get hypoglycemic. And we're going to measure finger, palm, and forearm blood sugars and see what happens. What they found is that your forearm blood sugar underestimated hypoglycemia. It was higher here compared to here, and actually what would be clinically significantly higher. It was like 54 here and 40 here. I love this. I'll take it aside in a second. But what they didn't do, what I wish they'd done in this study, is draw a blood sugar and send it to the lab as comparison. I don't really know what to do with this study. I'd really like to know, were any of them accurate? That'd be kind of nice to know. But they did find that so say you're sucking blood out of an IV, you've got a saline lock. That's where you're checking your blood sugars. They imply that it may overestimate somebody who's hypoglycemic. So if somebody's a little loopy, you get the sugar here and it's 56. they may actually be hypoglycemic if you really stuck them here. So they imply that you might want to check, just be careful where you check your sugar, and that's what they imply. But they didn't do a really good study to know that. I think it's interesting. The studies this is hard to do in the United States. This kind of study on healthy volunteers, but when I was a resident back I did 2 residencies, one in San Francisco and one at Harbor-UCLA. When I was at Harbor, this was back in the day where they could take healthy volunteers are always medical students or residents. They just are, because you are a captive audience. And they did a bleeding study on us, basically. It was a hypovolemia study, a trauma study. They wanted to see what happened to vital signs, both supine and orthostatic, if they bled us 10, 20, or 30% of our blood volume. So they took all of us in the residency. We basically, literally, they weighed us. They figured out what our blood, they bled us 10, 20, or I was in the 30% group. Blood volume, they basically bled us down, checked our vital signs, and then checked our orthostatics. Because we're all told everybody gets tachycardic and hypotensive and blah, 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 which is a big old lie, by the way. About a third of us got bradycardic. One guy went flat out, fainted. In fact, he fainted, hit his head. And he's now chair of a Department of Emergency Medicine on the East Coast. I'm not sure what that means, but it was interesting. You can't do those kinds of studies anymore. They don't allow you to do that anymore. The next 3 abstracts beg an issue. Those of you that are in base stations, you get the call. I love the start of these calls. Is this an AMA call? It's a documentation only call. Hate those. Hate those. We were called to the scene if somebody was altered. We checked a blood glucose, it was low. We gave the D50, now the patient's refusing transport. Is that a safe practice? Well, that begs the issue whether you can even transport somebody who refuses, who's now awake alert with the program and could say, I'm not going. I'm not going. Is it a safe practice? Not clear. The first abstract, number 2, tries to look at that. And what they did in this particular paper is it was 374 patients with hypoglycemic prehospital episodes. They all got seen, and they looked at what happened as far as recurrent EMS calls in the next 48 hours, if they were transported or not. If they weren't transported, about 6% got calls back, about 4.5% got calls back if they were transported. So the reality is hypoglycemia is a common deal. And in people that tend to it, we'll talk about who they are in a sec, people who tend to it, it tends to recur. I like abstract number 4. They tried this, God bless them. They tried to do this big old protocol where the paramedics were trained in this protocol and they had all these things they had to do in the field. And if a patient wanted to sign out after they got their sugar, they had 18 items they had to check off. Yes, okay, okay, okay. All right, you're allowed to do this. What they found basically is this protocol failed miserably. And they, quote, didn't adhere to it more than half the time. But who in heaven's name is going to go through an 18-point checklist on every single person who wants to sign on AMA? They did have one bad outcome in this. It was a repeat offender, somebody who got called on all the time, who they didn't transport, who did get recurrently hypoglycemic and ended up with permanent brain damage. Can that happen? Sure. But again, it begs the issue. If you give sugar to somebody and they now are awake alert with the program, they are completely allowed to not be transported. They're allowed to sign on AMA as long as they understand that depending what agents they're taking, this may recur and unlikely will, unless they don't eat something well, that this may occur. So that kind of begs the big picture, but it's kind of an interesting concept. I was taught, if we get into the next section, again, lies they teach you. I was taught that if you give you give a D50 amp to somebody, their blood sugar will go up by X amount and it will last X amount of time and blah. I was taught this. Baloney. Abstracts number 5 and 6 look at this. Abstract number 5 looks at it in 23 diabetics and 28 non-diabetics. They gave an amp of D50 and they wanted to look at what happened to their blood sugars. Well, it went up from anywhere from 37 to 379 milligrams per deciliter. Totally unpredictable. And it had nothing to do with whether you were diabetic or not. It had nothing to do with that. And the next paper, which is healthy volunteers, gave an AMP of D50 to 10, I think it was 25 healthy people, gave an AMP of D50, and what they did is they measured blood sugars. It was basically 0.0, 5 minutes, 15 minutes, 30 minutes. It peaked at 5 minutes. It went from a baseline of 80 to 244, but by 30 minutes it was back right down to baseline. So you don't get a long time, and you can't predict how high it's going to be, but you do get a little bit of bang for your buck in giving sugar. I think the key to this is just don't count on it keeping somebody's sugar up, and we're really good at that. We're really good at knowing to recheck and knowing if somebody gets a little loopy, they may still be, their sugar may have dropped again. We're pretty good at that, especially if they've taken an oral agent and they're hypoglycemic, or they're on a long-acting insulin and they're hypoglycemic. Those are the sort of 2 biggest causes. Let me give you a scenario. Patient comes in with a 900 milligram overdose of glyburide. 900 milligram overdose of glyburide, and comes in with a blood sugar of 0. 0. So you give an amp of D50, you give another amp of D50, you give another amp of D50, you give glucagon, you give everything you possibly, you got them on a D10 drip, you got it, and the blood sugar is 10. What do? Well, what glyburide is a sulfonylurea. What sulfonylureas do is they basically stimulate insulin release. The problem is, so does your D50. You're giving D50, and it stimulates insulin release. So what you're basically doing, D50 may correct people, but it also stimulates, if they have any insulin to release, it stimulates it, and it keeps their sugar down. Can you treat those people? You can give them sugar sometimes until you are blue in the face, until you have volume resuscitated them with D50. Can you do anything else instead? Yes. Go next door to the variceal bleeder, take that octreotide, unplug it, and plug it in to your overdose patient. Octreotide actually inhibits insulin release. And it turns out that it has this magical ability to fix these people. Sulfonylurea overdoses, either inadvertent or on purpose, if they stay hypoglycemic despite your usual treatment, you can use octreotide. These abstracts, number 7, 8, 9, and 10, the best of which is, I believe, number 9. Number 9 is one of those best evidence topics reports. Look at this. And so far, it's been mainly case reports, no real controlled studies yet, although abstract number 9 is a study. The doses are kind of all over the map, and the doses recommended in general are anywhere between a 50 to 100 microgram bolus, which is sort of what we're used to doing around that for variceal bleeding, and then an infusion of anywhere up to 125 mics per hour. And these people's sugars will absolutely stabilize. Then they metabolize off their sulfonylurea, it's done. This is magic. Put this, so if you see a hypoglycemic patient and they've got glyburide or glipizide on their list of meds, and you can't get their sugar up, the nurses are gonna think you've lost your mind, but tell them to get octreotide. It's actually remarkable. It's pretty amazing stuff. So it's worth knowing this. Put this in your armamentarium. Very worthwhile treatment to know about. There are studies being done on this now that I'm aware of, but right now we don't have any great studies, but it definitely works. Very little downside at all.
Is there any difference if it's a diabetic or non-diabetic patient that took the glyburide?
No, there is not a difference if it's diabetic or non-diabetic, because it's basically acting at the insulin release level. So there is not a difference in those two cases. The one thing they tried to do in abstract number 9 was look at if it was an inadvertent, somebody just took too much of their own medicine or they were hypoglycemic on their oral dose, could you treat them with octreotide and then send them home? And that turned out not to work. And that makes some sense, right? Octreotide has a relatively short half-life, and glyburide has a very long half-life, 24-hour half-life. So it makes some sense that you can't, they were trying to see if you could just get this person home, but you can't in these cases. So they tried. It was a good try. Yeah?
Do you think we should use the same dose as we do for variceal bleeding?
I think to keep it simple, using the same dose as various, because right now we don't know the exact dose. Anywhere between 50 and 100 has been used successfully. So we don't know the exact dose, and since we're comfortable with usually 80, most of us usually pull out the dose for variceal bleeders, I think using that same dose is just fine. Just fine. Yeah?
Do we have any dosing for pediatric patients?
Good question. No. This has not been observed. It hasn't been, to my knowledge, there are no pediatric even case reports on this. I don't know if you know, I'm not aware of this at all in kids. Most of this is adults. And actually the sickest kid I ever saw who took in sulfonylurea the sickest person was a kid who inadvertently overdosed on mom's sulfonylurea and was hypoglycemic for days and days and days and days. It was really sick kid. I hate the next paper. I just want to, whoever, Weezar, abstract number 11, whoever Weezar is, I want to slap. Honestly, this paper, what they did is they took 88 people who were diabetics who had myocardial infarctions and divided them into who was on a sulfonylurea and who was on something else for their diabetes. And then they looked at their EKGs. And what they found, and it's a weird study, but that the people on sulfonylureas had less ST elevation than the people who weren't on sulfonylureas. And their conclusion says, perhaps we should have some sort of different standard in diabetics on sulfonylureas as far as considering something as STEMI, so we can give them the benefit of PCI, et cetera, et cetera. What in the hell do I do with this paper? This is like some attorney going, yeah, like this one, I'm going to put this one in my armamentarium. But it helps us not at all. I hate this paper. And it comes up in all kinds of these kinds of diabetic talks, and I really hate that paper. All right, what about this? I love this. I had a patient I saw recently who came in and said, I've been type 1 diabetic. I've been diabetic for a really long time, and you know, I'm really excited because my diabetes is getting better. I said, really? He said, yeah, I'm needing less insulin. And I just thought, oh, honey, your renal function's going through the floor, right? Because diabetics who suddenly either get sort of hypoglycemic, insulin-dependent diabetics, who get hypoglycemic episodes kind of more and more often, but they're on the same dose, or, oh, I don't need as much insulin today or next week or the next week, usually their renal function is going through the floor. And abstract number 12 is just a case report that drives the point home on a case of a person who basically had a diabetic, type 1, who had non-steroidal-induced renal failure, didn't know it, and came to the hospital with multiple episodes of hypoglycemia, refractory hypoglycemia, because remember, a third of insulin is metabolized by your kidney, and if your kidneys aren't working, your insulin hangs around a long time and you get hypoglycemic. And abstract number 13 is kind of interesting. Diabetics often have renal disease, and once they get to the renal failure end of renal disease, end up with they're anemic because of their renal failure. This one basically said that our blood reagent strips, the strips that we use, the more anemic you are, the more likely they are to overestimate your blood glucose. So if you have a renal insufficiency or dialysis-dependent diabetic who comes in a little loopy and their hemoglobin is 8, and you do a blood reagent strip, it may actually, because there's more plasma ratio to red cells now, it diffuses. The theory is it diffuses across these things quickly and measures higher. It may overestimate the blood glucose. This is actually a pretty decent study. And I think it's something to just throw into your brain. If it comes back at 80 or 90, but the patient's a little loopy, it may not be that high if they are anemic. So just kind of throw that in as a subtlety in your diagnosis. I think that's kind of cool. I have a question for you. So somebody does a finger stick sugar, it comes back critically high, because it always comes back critically high. In our waiting room, it comes back critically high because we stick them out there long enough to watch the natural history of their disease, and they go from a little bit of an elevated sugar to raging DKA. So and that critically high is one of our alarm values, and so I get notified of these. Is there any test I can do fast to see if that patient's in DKA or not? I hear it. Urine. Urine what? Urine dip for? It's so fabulous. It's fabulous. So, because, God, I don't know, sending stuff to the lab takes forever, and it's a pain in the neck. And these next two papers, they're a little bit old, but nobody's repeated them because you don't have to. Okay, these papers are great. Abstract number 14 defined DKA as the following. So this is a study they did in patients, but they defined DKA as a glucose greater than 200, a pH less than 7.3, or a bicarb less than 15, and ketonuria, or ketonemia. I think we'd all agree, and that's actually the Diabetes Association definition. We'd all agree. And they define DK as the first two, or as ketonemia and a sugar over 200, but no acidosis. I'm cool with that. And what they wanted to see was if I dip the urine and I compare it to anion gap, serum bicarb, is the urine dip going to pick up these DKA cases? And actually, it turned out the urine dip was better than either using the anion gap alone or the bicarb alone. The sensitivity, specificity were in the high 90s to 100%. The negative predictive value was 100% in one of these studies and 99% in the other. Fabulous, 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 fabulous. It's really great. What it liberates you to do is that person with a blood sugar of 330, you dip their urine, it's negative for ketones, you're done in that whole DKA department. You don't even have to go there. It's marvelous, marvelous, marvelous. You have to be able to, we can't dip urines in our emergency department because the CLIA requirements are a total pain in the neck. And I think there's some sort of cahoots in the lab because they can charge for it, and we don't charge for it in the ER. But separate from that, it's a fabulous test. And I highly recommend doing urine dips to rule out DKA. It saves you all the lab test stuff. How about if you think that somebody's in DKA, what about the blood gases? How many of you are doing exclusively VBGs these days? You are right on the cutting edge. There really is virtually nothing except perhaps the cardiac arrest patient and perhaps the bad COPDer, the retainer kind of person. Those are the only two cases where an ABG may have a little bit of benefit over a VBG. But honest to goodness, if you really want to know a DKAer's pH, do a VBG. You draw in the blood anyway, send it off to the blood gas lab. Your pH is absolutely, that's what you're looking for mainly, is the pH. It is clinically equivalent in DKA and uremia, renal failure patients, to do a VBG or an ABG. There just is no need. And if you've ever had an ABG, I've had several, they really hurt a lot, and they're very expensive. They're anywhere between $150 and $250 per ABG. VBGs are not as expensive, easier to do, really easy to draw. So if you really care about the pH, and I'll tell you, honestly, only if they're really sick do you care, and all it does is makes you want to do something about it, which you probably shouldn't go crazy about the pH. I'm not sure you even really need to check, but if you really, really want to know the pH, do a VBG, not an ABG. I'm going to skip abstract 21 because it's a little bit of an odd study. But let's say you have somebody with a critically high sugar, you've dipped their urine, it's ketone positive. Okay, it's probably DKA. And you've gone and gotten that VBG and their pH is 7.2. All right, fine. This person's in DKA. Cool. Most of us give IV insulin for treating this. There are all kinds of protocols, and I recommend protocols, by the way. I'll tell you why at the end of this, but I strongly recommend a protocol. At least you have your own. And the American Diabetes Association has a great protocol they recommend. Particularly the thing we don't check well is checking a potassium before we start insulin. Please never start insulin until you check a potassium first. About 5 to 10% of DKA patients will be hypokalemic on your first potassium check, and insulin drives that into cells, and I've seen 2 patients go into cardiac arrest from hypokalemia who were given insulin before their potassiums were checked. So please be careful with that. But do you need to give IV insulin? We all have our formulas, 0.1 per kilo per hour, so it's 7 units an hour, blah, blah, blah. We've all done this a million times. Can you give less? You bet. There's an abstract in here that looks at this, abstract 22 by Wagner, kind of smallish study, but basically makes a case for very low dose insulin and used anywhere between 0.5 units an hour to 4 units an hour in these patients, and they actually cleared as well as somebody who got the sort of 0.1 per kilo dosing. Cleared as well. Oh, by the way, you don't need to give a bolus. The studies that have looked at giving that bolus of insulin first to coat the tubing, let it attach to all those little tubing receptors for insulin. Why insulin sticks to tubing, I don't know. But it turns out that the bolus is unnecessary because if you look at the outcome studies, they don't get better any faster getting a bolus. So the bolus isn't necessary, and it runs a risk. If it's inadvertently given the wrong dose, it runs a risk. The IV insulin dosing of 0.1 per kilo isn't magic, and lower doses can work. And I got to ask you, do any of you in this room give the analogs sub-Q as treatment? There are 2 papers in here by Umpires, and Umpires is pushing this, and it's probably the only person I've seen study this, but it makes really good sense. That these are analogs that we know very well their profile, when they kick in and how long they last. Okay, we know and they kick in quick, and their duration is very proscribed. These are much more predictable than human insulin is. What Umpires did is basically gave sub-Q doses every hour in people in DKA. Actually, the doses range a little bit in there, of these analogs, these sort of synthetic analogs, and these patients did just fine. No IV needed to be prepped. They didn't have to, this could theoretically not be done in any kind of monitored setting, except for checking sugars. It's kind of interesting. I know when I've been asking around like that, I've even asked our endocrine folks why they don't do this, because it actually makes a lot of sense to consider this. It's not done routinely, kind of interesting concept, but insulin right now is the sort of mainstay of therapy. And how about bicarb? So I'm going to give you this. The patient has DKA and their pH is 7.2. Who's going to give bicarb? 7.1. 7. 6.9. Who's going to give it? I'll tell you this, and it really gets to one of these like, okay, how low will you go and where do you start to get antsy game? If you look at the literature, there's a few papers in here, and actually there is a plethora. These are actually sort of small studies, but there are probably now 30 papers that look at bicarb, giving bicarb in DKA. And I will tell you, down to a pH of 6.9, giving bicarb has no effect in outcome, and in fact has a potential downside as far as electrolyte abnormalities that will be caused by giving the bicarb, particularly potassium abnormalities. Right? We give bicarb for potassium problems. You can drive their potassium into cells. So that potassium issue is significant, and it's a big sodium load. So know that bicarb, it is so tempting. You hear the discussions. I don't know, the pH is 6.9. What do you think? Well, I don't know, I'd give it. Well, I wouldn't give it. What do you think? The reality is it does not change outcomes, and we care a lot about outcomes. It is discouraged, and even if you go look at the American Diabetes Association's recommendations, it's discouraged until you hit a pH of about 7. And then you think about it, and then lower than that, it becomes a debatable point. But honestly, down to 6.9, according to the literature, no change in outcome. How about kids with DKA? Now this is we have a pediatric emergency department as part of our ER. And kids in DKA are nerve-wracking. Okay, they're scary, they're sick, they're sick. How good are we at figuring out how dehydrated they are? We're not. And abstract number 28 is elegant. Elegant. It is estimated that kids who have DKA are about 10% dehydrated, whatever that means. And they looked at this and they said, okay, all of you docs, we're going to take kids with DKA. There were 33 of them. And I'm going to ask you and you and you and you and you, what percent dehydration do you think this kid has? Write it down. And then what they did is that they did a very simple thing. They weighed the kid on presentation, they weighed the kid at discharge, and they weighed the kid at follow-up. And they figured out ideal body weight, and then they compared it to what their weight was on presentation, figured out how dehydrated these kids were. Elegant, lovely, simple, fabulous study. What they basically found is that the dehydration ranged anywhere from about 1.5% to as high as 15%. We were completely off as far as our estimation of dehydration. In fact, we tended to overestimate dehydration, and the median was 6%. So in this study, basically I think what it's driving toward is that the kids with DKA were not as dry as we tended to think. And it's important because fluid resuscitation in kids with DKA is a bit controversial. So I think this study is excellent as far as pointing out that kids may not be quite as dehydrated as we think they are when they present. And the reason that's important is cerebral edema. You all have heard about it. It's all buzzed about. Our pediatric emergency folks talk about this ad nauseum. The whole next set of abstracts looks at the concept of cerebral edema. 33, 34, and 35 are the best. Circle those. 33 and 35 are reviews. 34 is the best study to date looking at this, the biggest and best study to date in children. Let me give you some information. In children with DKA, the risk of cerebral edema is 1%. And actually, study after study after study, it ranges between about 0.8 to 1.5, so about 1% is the risk of cerebral edema. If a kid gets cerebral edema, their morbidity risk is about 40%. So we're getting into some, it's serious business. And I've seen 2 deaths from cerebral edema in my career. It's nasty stuff. It's pretty scary, nasty business. Do we cause this? Are we the culprits? Do we make this happen? The preponderance of the literature says no. The preponderance of the literature says the kids that get this are the kids that come in sick because they have bad diabetes, and it is more common in first presentation diabetes, which makes sense. Nuance at diabetes. Makes sense. The parents know that the kid's not doing so well, not eating really well, acting kind of fussy, weird. So it takes a while. It's versus my kid has diabetes. I know they're not doing well today. I'm going to bring them right in. Versus the kid that's new and they're just acting a little weird and they come in sick. And we don't know they're diabetic either. So we receive this sick kid who's dry and irritable and acting a little off and just looks terrible. So we resuscitate, as we should. Those are the kids that tend to have the bad problems with cerebral edema. The key to this is, and if you look at the papers, remember that they tend to be dry, and you do need to resuscitate. There is a loose but probably not appropriate correlation between fluid rehydration. You don't have to go wacko with it, but do resuscitation. So if a kid is truly dry, give your 20 milliliters per kilo bolus. Do it. See how they look. You don't have to go nutso. Okay, you don't have to go. And there's one study in here where they got up to 70 to 80 per kilo resusc in these kids. You don't want to go that wacko either. Get them to a resuscitative state, but we probably don't cause this. And that's why I like abstracts 33, 34, and 35, because it gives you some peace of mind of knowing that if you do what is medically appropriate, not going nuts with the fluids, that if a kid gets cerebral edema, it's not you, it's their disease. They have bad disease. And I don't know how you guys manage them in Miami, but
That's been our experience. A couple of really bad ones with the nuance of diabetics. And over the years, become less and less aggressive.
yeah.
It used to be
Well, and I think what's interesting about DKA, when I did my medicine residency, we went wacko with saline. We resuscitated with fluids like crazy in DKA, pediatric or adult. We would dump in 3, 4, 5 liters. You don't need that. And in fact, what you're going to do, if you give somebody with DKA, particularly an adult with DKA, if you give them 5 liters of normal saline, what you're going to do is correct their gap and not correct their acidosis. Because you're giving them chloride. And if you follow, I'll tell you, go back sometime and watch your labs. If you give too much fluids, what's going to happen is their gap's going to narrow and their chloride's going to go up to 112, 118, 115, and your bicarb's going to stay at 15, 15, 13, 16, 15. It's going to stay the same. Your gap is gone because it's all chloride. You've done it with normal saline, but you haven't fixed the DKA 1 iota. 1 iota. So the fluids are not the issue. It's the metabolizing the ketones that are the issue. So don't go too nuts with the fluids. It's the metabolizing those ketones that are the problem. Now the last paper in here looks at, the last one I'm going to talk about, because we'll talk about abstract 37 day after tomorrow. The next section, the wrap for today, is our protocols useful? We're just working on we don't have one actually. We have protocols for down everything but this at Harbor, but we follow the ADA guidelines in general on how to manage this stuff. This paper looks at if you establish a protocol, a checklist. And this one's if you pull the paper, this is an excellent, if you want an example of a checklist, this paper has a really good one. What they did in this is they basically said, here's how we're going to manage DKA patients. Once we diagnose it, here's the labs we're going to check, here's how we're going to give the insulin, here's what we're going to do is when we're going to give add the sugar back, here's what we're going to do. And they compared those patients, there were 111 of them after the protocol started, they compared them to 130 patients before the protocol started to see what happened. They did great, and 2 huge utilization factors were affected. ICU time decreased by 10 hours, which in a hospital, if yours is like mine, 10 hours of ICU bedtime is very valuable, and their length of stay decreased by over a day. Their labs improved more rapidly, and there was no downside to this protocol as far as symptomatic hypoglycemia episodes or recurrence of anion gaps. And in fact, the recurrent redevelopment of anion gaps was less. So I recommend a protocol. Diabetes is complicated business, and DKA is something that you can protocolize overall. So it's actually a very useful thing. Any questions on this jazz?